Good morning. I think we can get started with this session. What's wrong?
Good morning.
Good afternoon. So, okay, it's the same. It's a good day. Okay, it's better.
So that's my role.
Okay,
I'm
I have my teacher together. Yeah, it's like that.
I'll help you when you stumble.
Okay, Anyway, this is going to be really promising from the very early beginning. Okay, my name is Giuseppe Tarantini. I had the pleasure, to co-chair the session with Nicolas van Mieghem and a distinguished panel of speakers, etc. And, I think we can start with the session objective. Would you introduce me, Nicolas, for the for the session objective?
Of course. So it's my great pleasure to introduce Giuseppe Tarantini, who is the current president of the Italian Society of Cardiology.
It's not like that.
Of the former. So we are. So first of all, we would like to thank Boston Scientific for sponsoring this session, and it will deal with all kinds of ways of limiting TAVI-related complications and promoting early discharge. And I hope that we can demonstrate how to obtain early discharge protocols and how to use also accessories to reduce complications. So Giuseppe, for you, the introduction.
Okay, thank you, Nicolas. So to me, my task is just to discuss about the session objectives. This is my conflict of interest. So session objectives. Attend this session if you want to understand how to simplify TAVI, how to facilitate the early discharge, to review the current data and understand the steps of cerebral embolic protection, to learn how to anticipate PVL and assess device options. This is the session program. We have the rationale for embolic protection as a standard of care by Nicolas Dumontel. We have case one, minimalistic approach, TAVI with embolic protection, preventing complication for early patient discharge from RAC. Then we have a discussion. I think you have to feel, engaged from the very early beginning. I think this is the goal of this session. Then we have Van Mieghem with predicting paravalvular regurgitation after TAVI. Another case, the new lotus edge in complex anatomy by Carbanda. Discussion again with the audience and session evaluation by Kim. So my last two slides is about what this session should be. This session should be small, interactive, facilitate discussion, might be considered an opportunity, informative at the very end, need to be fun. So here the list of the do's and don'ts. So let's do's like that and avoid to do like that, quite submissive, sleepy, and dutiful. So I think having said that, the mood is the right one. We can start with the session. Thank you.
And with that, it is my great pleasure to introduce my good friend, Nicolas Dumontel, who is in Clinique Pasteur in Toulouse, and he's going to discuss the rationale for embolic protection as a standard of care in TAVI. Nicolas.
So thank you, Nico, and thanks again for this invitation to discuss about this topic that maybe we can turn into a question. Is there a rationale for cerebral embolic protection during TAVI procedures? And what I can propose is just altogether to go through the intellectual pathway that allows us to examine whether there is a rationale for that and how strong it is. So what do we know? We have some reasonable amount of evidence since TAVI has been diffused. And we know that there is obvious central nervous injury during TAVI procedure. The most apparent and the most feared part of this central nervous injury are the overt and what we call now disabling strokes. And you have here a wide illustration of the different rates of strokes reported in various contemporary TAVI studies, most of them focusing on disabling stroke, and as you see, with an average rate of 4%. But as we know also, the quality and the exact rate of those cerebral events are highly dependent on the nature, on the sensitivity, and on the timing of the detection those events. And it's perfectly known also with TAVR that when you use routine discharge exams by neurologists, you detect, you show a higher rate of stroke. So the actual rate of stroke after TAVI is probably higher than the one that is reported in the contemporary TAVR study, at least the ones who are not using this robust methodology. And what we know also is that each time we have such a clinical, very important event, neurological event, it's associated with a 4 to 6-fold increase in mortality after TAVI. You see here data coming from 2 large meta-analyses on the left with more, or at least 30,000 of patients on the right with more than 10,000 of patients grouped into those 2 meta-analyses. A lot of complications we've noticed since we've been implanting transcatheter heart valve are decreasing with activity, with side volume, with experience. It's true for mortality, it's true for vascular complications, it's true for bleeding. And unfortunately, it's not true for stroke. These data are coming from the TVT registry analysis, more than 40,000 commercial TAVI procedures analyzed, that clearly show that there is no significant association between TAVR volume and side experience and stroke rate, unfortunately. And what we know also for years now, because those studies mainly were done years and years ago, is that when you look for a central nervous injury with neurological exam, with more precisely MRI studies routinely done after TAVI, you find some silent brain infarctions in up to 80% of the case. And we know also, driven from large population-based studies, that it can lead to dementia, to cognitive dysfunction, and at last to increased mortality. So all of this can be summarized by this simple and trivial image and comparison. There is an important cerebral damage is TAVI. Most of this is unseen, that is disabling stroke, and we've seen that a lot of this is not unseen or most of the time underreported or not detected. And last, what we know also is that most of those events are related to the procedure, and most of them, more than 50%, are occurring during the initial periods, and most of them are what was called major stroke at the time of this analysis, that is called now disabling stroke. So if we summarize this first part, we know that brain injury is frequent after TAVI, and we know that it occurs during the procedure. Where it comes from? So it comes from various sites, various theoretical supposed origins that you have on your screen. Of course, it can come from the transverse and aortic arch, from the ascending aorta, coming from atheromalacians, from the stenotic valve itself, from the TAVI device that can be damaged for the myocardium, and for all of those origins. And 6 years ago, Nico and his team started to use the Sentinel cerebral protection device, that is this dual filter system that you know that allows you to protect the nominate artery and the left carotid primitive artery, and to collect the debris that occurs, that embolize during a TAVI procedure. And by analyzing it, by having an histopathology analysis of this, they demonstrated 6 years ago that at least 75% of the patient had debris coming from the aortic wall, coming from thrombus, coming from collagenous tissue, valve tissue, thrombus, calcium, or even foreign body. You have here example, obvious visual macroscopic example that makes things more concrete, of course. And we know since then, with a larger number of patients studied with such device, that you can reach even higher rates of debris capture during routine TAVI procedures. And you see that in the Sentinel IDE trial, 99% of TAVI patients had debris captured in the filters with almost the same repartition of origin that Nico showed in his study. So if we summarize the second part, we know that brain injury is frequent after TAVI. It occurs during the procedure. We have devices. We talked about the sentinel device, but we know we have also deflectors that are covering the vessels at the level of the aortic arch, avoiding to embolize to the brain. So we have devices allowing to avoid embolization of debris to the brain during the procedure. So the link between both seems obvious. This is a proof of concept. So what about clinical efficacy? But unfortunately, as you know, those devices have been tested in several comparative studies, including randomized controlled trial, that individually did not demonstrate any significant reduction of stroke or mortality. And probably the main explanation for that was that those trials were maybe not adequately powered, and we will have maybe the opportunity to discuss that, adequately powered to detect such clinical difference regarding hard clinical endpoints. So, as it was anticipated, this was grouped into meta-analysis. And here is a meta-analysis that grouped 5 randomized controlled trials that tested cerebral embolic protection devices that showed a significant reduction of 40% of the occurrence of stroke or death at 30 days. But on the other hand, another recent meta-analysis grouping either randomized study or non-randomized comparative study failed to show any significant difference regarding the risk of stroke at 30 days. So what those two meta-analyses tells us is that there is a wide heterogeneity in the data we have to date and in the evidence we have to date regarding the clinical efficacy of those devices. But more recently, as you probably saw, there was a propensity-matched analysis that grouped several comparative studies only with the dual-filter embolic protection device compared to a control group, and that showed a 65% reduction of the occurrence of procedural stroke in the 3 initial days after the procedure. So to conclude, we see and we know that brain injury is frequent after TAVI. It occurs during the procedure. We have devices allowing to avoid embolization of debris to the brain during the procedure. And we have clinical evidences that are pointing towards the right direction, but there is still need for adequately powered randomized controlled trial. At the end of the day, as physicians, we have to have convictions and to treat our patients. So let me just share my conviction that is, of course, personal as physician and as implanter of transcatheter valve, is that if I had the opportunity to protect the brain of my patients for all my TAVI procedures, I will probably do. And if tomorrow I have to ask to my partner Didier Cheche to treat my father or my mother for TAVI, I probably ask him to put a cerebral protection device for the procedure. Thank you.
Okay, so that is an interesting presentation, and I think I am totally aligned. So I think the basis is that there is, at least according to your opinion, cerebral embolization during a TAVR procedure in virtually all patients, correct?
Yeah.
So what I would like to learn from the audience, because I'm also convinced, but who is doubting that there is cerebral embolization during every TAVI? Can you raise your hand if you are in doubt?
You scared them. You have to rephrase. You have to rephrase. How many of you do have experience or have used cerebral protection device in your experience? Raise the hand. He says less.
Yeah.
Do not shy away. Do not shy away.
That's a different question. That's a different question. So the question is: so if you believe that there is cerebral embolization and you're not using it, why is that? Is that because of financial issue,
Yeah.
or is it because you think, okay, there is embolization, but it's harmless? Would you have a comment on that?
I think, and again, coming from real life and everyday practice, in my personal experience, the main reason is that we don't have a reimbursement in my country for all TAVI procedure with this device.
I have a point for you. I have a point for you, Nicolas, and for the two Nicolas. Okay, the point is the following: based on the recent release of low-risk patients, TAVI source 3 and core valve low risk, it seems that the stroke rate is getting lower and lower. So it seems to be a clear correlation between the risk profile of the patient and the final stroke. So the data that we have pertain mostly to high-risk patient, intermediate-risk patient. So what's your perspective when we tackle lower but younger patients? So this is a very difficult question.
But of course it's just an opinion again. It's not evidence-based, but my opinion will go into two directions. First, regarding the apparently really low stroke rate reported in those two trials, I think it goes with the hypothesis that most of those embolization events are coming from atheroma, calcified lesions, calcified valves, and maybe those younger and lower risk patients had a less atheromatous burden than the higher risk patient we had. It's an hypothesis. We'll see. Second part of the answer is that, of course, as we all do, we have to be cautious with those data because it's only short-term data. And what we know, not only from TAVR study, but other studies that are linked to this field, is that cerebral injury related to those embolic events will have some long-term consequences, probably. So maybe if those young patients paid a lower price regarding the stroke risks in those trials, we are not totally aware whether they won't pay a higher price caused by embolic events at long-term follow-up.
Okay, thank you, Nicolas. We are a little bit behind the schedule, so let's invite Andreas Rook to the platform with the case number 1. This is a live in a box. So please feel engaged, so you can interrupt us, at your earliest convenience.
Thank you very much for the invitation. You will see a case using the Boston Accurate valve and the Sentinel, but also other things to highlight a streamlined process for the patient and the so-called minimalist approach. These are my disclosures. So what's the minimalist approach and what's the idea behind it? To make it really short, it's, in my opinion, to avoid all the so-called collateral damage, that you should treat the valve, of course, give the patient a good valve result, but alter as little as possible with the patient in other respects. And just as a side note, all the recent data, as you know, in TAVI has been generated in femoral access patients, so probably by default the non-femoral access is probably not considered a minimalist approach. So how do we achieve this and how do we avoid this collateral damage? It's, I think, by stepping away from some things which have been traditionally used and probably come as luggage from the surgical tradition, which is, for example, intubating the patient, sedating the patient, giving them a urinary catheter, a central venous line, and even to give them a transvenous temporary pacemaker. As you will see in the case, the accurate valve has a really low pacemaker rate, and it's quite easy to predict the patients who will have the risk of getting a complete AV block, and these are the patients who would have a RBBB before the procedure. The other patients will have a pacemaker risk which is less than 1%. So then, as you will see, with the accurate, it's recommended to do the pre-dilatation, then you can pace over the left ventricular wire, which you have anyway in the patients. And key, I think, to short hospital stay is to have a short protocol in bed and to mobilize really quickly. And it's also helpful, of course, if you have few patients where you are in doubt that you need longer monitoring of the ECG to rule out any AV block. Then we come to the femoral access, which we have focused on a lot at my institution the last years to get a really high transfemoral rate. What is new since last year is the new expandable sheath from Boston Scientific, the iSleeve, which we've used more than 1 year now at our institution. And initially we collected the data on the patients which were within the range, official range, which is 5.5 millimeters femoral arteries. And then we also collected a number of patients and used the product in femorals as small as 4 millimeters, and that's including 4 millimeters and calcification. And so far we have very few complications in these patients, and we now, since last year, also have the shockwave balloon available to enable the femoral access. And so far, actually this year, we have a 100% femoral artery access in our TAVIs. I think this sheath has made a big difference for us, at least. Coming to the case, you will see soon a 10-minute recording, and I'm happy to take any questions or interruptions from the audience or from the panel during this video. This was recorded 3 weeks ago. It's an 83-year-old woman. It's a quite regular case, nothing very unusual here. There are symptoms of aortic stenosis. There is a clear aortic stenosis on the ultrasound. There is normal LV function. We discovered 2-vessel coronary disease, which was treated with 2 stents. And she also was scheduled to have a spinal stenosis operation, which was preferred to do after the TAVI. Calculated Euroscore 2 was low 1.7%. On the imaging, we have a tricuspid anatomy. We have a 23.7 millimeter perimeter-derived annulus diameter. We have normal calcification of the leaflets, and we have no major calcification in the annulus, as you see in the pictures. And the coronary ostia are at a high distance from the annulus too. So nothing special there. And actually here also nothing special. The femoral access is rather good. The right side iliac is a little bit more tortuous than the left side, so therefore the left was preferred in this case. If you want to use the sentinel, you should look at the innominate artery, that's the brachiocephalic artery in Latin, and you should measure its diameter, and you should also measure diameter, more importantly, of the left carotid. There shouldn't be any stenosis, and the diameters should be, in one case, in the first case 10 millimeters or higher, and in the second 6.5. It's easy to do with the regular planning tools and use the regular CT pictures. So the plan for this patient is to use the left femoral artery, use this iSleeve 14 French expandable sheath. We put the pigtail from the right femoral artery, we put the sentinel from the right radial artery, and the ACT should be over 250 seconds before we insert the sentinel. We do the pacing over the left ventricular wire. Since there is no bundle branch block in this patient, we will predilate with a 22 millimeter balloon. You remember it's a 23.7 annulus. There is no need to be aggressive with the predilatation with the accurate valve in our experience. And then the valve will be the medium-size accurate neo, which is nominal 25 millimeters. And we'll close the main access with a closure device. The plan is for the patient to ambulate after 3 hours and go home the next day. And the recording will show me as operator and my colleague Magnus Zettergren. Just on the devices we use, the accurate neo looks like this. Most here in the room are maybe familiar with it, but it's a nitinol self-expanding valve. It has porcine leaflets. The leaflets are supraannular, so the gradients you get are usually really low when you implant the valve. The shape of the stent is also not completely straight. It has this so-called upper crown, which helps with the positioning of the valve. The sentinel was shown previously. This is the same picture actually. So it's a 6 French device. It goes through a regular radial sheath from the right side. And as you will see then in the recording, it has a deflectable tip and it has these 2 independent filters. So now
we
have the wire down in the ascending aorta.
Yeah.
You see on the fluoro that this device is coming down. We have the pigtail as a marker of where the aortic curvature is. This maneuver, Magnus was dragging the wire to the descending, which sometimes is a good idea, although it's not how it is written in the instructions for use.
The wire, by the way, is a regular PCI wire. It's
keep the wire still, go down with the
0014.
And then, like
quite often when you do radial PCI, you ask the patient to take a deep breath. So now you are able to see the two filters inside the catheter. Have a little bit of attraction to the catheter because it has a tendency to go down. So
Just showing Magnus a bit where exactly where the aortic curvature here, which is here.
Yeah.
I'm not sure if is there a point there?
all right.
You see in the floor image in the upper left corner, you see the filter coming out.
So now this is fully deployed. I can now make the device in the right position. So, and I will straighten it out a little bit in order
Now we
to...
try with the wire.
Yeah.
Yeah.
The wire then normally goes up, and we check that it goes up in the carotid. Okay?
Good.
So we normally don't make any root injection here if it's a smooth procedure. In order to snug the carina, I then now continue to pull the distal part of the device backwards like this. And now the carina is snugged. I lock the number 2, and now it's in order to deploy the distal filter. I open up and then push forward.
We've seen on the CT there is a kind of a curve on the carotid, but it seems to travel up nicely anyways.
Yeah. And then I pull the wire so that I only have a couple of centimeters out.
So what we'll do is a micropuncture, put in a small 4 French sheath, and then exchange up to larger sheaths. The strategy for the closure will be with the Manta device. We'll see that in the end too. Here on the ultrasound, we can scan up down. Here we have two femoral branches, and here we have the common femoral artery. So we'll try to puncture just above the bifurcation, about here. Going down with the needle, trying to go to the 12 o'clock position. Can appreciate here that I'm moving the needle. I give a little local anesthesia here just above the artery, which helps also, makes the procedure less painful for a patient. Trying to go for 12 o'clock puncture, which is about here. I go in. First wire to go in is a micro wire. So that's probably the safest way. Just positioning the peak there to mark the
wasn't shown the insertion,
underside.
but it sits in the left side.
Seems like the coronary stent is still there, in the left coronary. You can see it. Yes. Good crossing. Now we push down the catheter to the ventricle. And now we take the Safari wire. The pacing strategy for the predilatation will be pacing over the left ventricular wire. So we'll see soon that we will connect connectors to the wire and to the skin of the patient.
Our micropuncture needle here, and position a wire in the skin, and by that there is no risk of unintentionally hurting yourself. And it's also good that you can extend.
Gives you a little bit more reach so you come closer. And these are the two connectors that we will use. The red one will go to the patient's skin, so we can put that already.
The connectors or the cables are the same one. The
and
pacemaker
then when we
guys
have
use for
a
the
balloon
PSA,
or anything
for the
plastic
pacemakers.
between here and the heart of the patient, we can connect here. We will screen up in the arch just to check that we don't touch sentinel. See again, nice pass. Coming down with the balloon to the stenotic aortic valve. Just putting the dots on one on each side. Good. Magnus is connecting the black connector to the wire, and now we have a electrical circuit. And then du är klar med ballongen, va? Du är klar med pacen. Ja. Pacing on. Balloon up. Balloon down. Pace off. comes with a short loader. The idea is to put half of the loader inside the sheath and then push the system in a few centimeters.
Kan vi ta ner ljuset lite grann, tack?
I'll go in like 10-15 centimeters, and now I don't need the loader anymore, so I'll send it to Magnus. See, it's coming out now. This is the still unexpanded valve. Crossing the arch usually is really easy with this device. It's soft and bends easily, as you see here.
And no touching of the...
No touching of the sentinel. So despite being two Boston Scientific products, they don't meet really. Now we're coming into position.
And,
what we usually do is a slight adjustment of the angle so that we will see straight on perpendicular to the delivery system. Yeah, good.
Yeah. And you know
just
that
check that the pigtail is in position.
Yeah.
Good. So now it's soon time for the first injection to check the position before we start. Contrast.
perfect.
Little faint on the contrast, so we are at about 5 millimeters depth, which I think it's an excellent starting point. So we just keep it there, and Magnus is starting the rotation of the number 1 knob. And I'm being quite passive here and just having a little push on the system. Confirm contrast. Went up a few millimeters, and now I can still push it down a little bit. So we continue, and I have a forward push on the system to prevent it to go aortic. Contrast. Good.
Looks very good.
Good. So pigtail out, and then we deploy the number 2 step, and then it's going to be fully deployed. So while doing this, I'm having a slight forward push on the system. Now I see it's released. Now we'll pull out the delivery system, and Magnus is going to take back the wire a bit to lift us possibly to the middle part or the inner curve. And now here, there's, as you see, there's a little push to prevent us from being too much in the inner curve here. So far, it looks pretty dry, does it, Peter? Looks pretty good. Contrast. Yeah, I say only a minimal leak.
Yeah.
Do you agree, Magnus?
Yeah, I completely agree. Perfect.
So that was a regular case. I think we achieved a good result on the valve, and we did no collateral damage. The ECG was unchanged after the procedure, thereby facilitating the possibility of an early discharge. There was no relevant bleeding. The procedure time was short. There was low contrast use, and there was a short hospital stay. That means the patient could go home the next day. Okay, I'm open to any discussion or questions.
Okay, Andreas, yeah. So we have 12 more minutes for discussion, and I would like to open up the discussion. When you talk about an early discharge program, 2 questions there. Is it early discharge restricted to the transcatheter heart valves to be selected? So should you be selective for which device you would use for an early discharge program? That's the first question. And the second question, would you also use cerebral embolic protection in all your early discharge patients?
I think the embolic protection device adds quite little time to the procedure and doesn't change anything for the discharge protocol, so that's perfectly possible, of course. And maybe if you believe that it reduces the brain damage of patients, maybe it's easier to send them home the next day if there's less damage, I guess, although I have no data on that. And secondly, which valves does this fit with? I think the thing that is really a medical issue is the patients who have a intermediate kind of block on the ECG, where you want to monitor them for 1, 2, possibly 3, 4 days to see if it gets better or gets worse, if they need a pacemaker or not. If you have lots of these patients, then you will have a problem of sending patients home early. Like I said, with the Accurate, we have really few of these patients. We also have also low occurrence of the new LBBB in the patients. Possibly there are other valves with the same possibility.
Andreas, you didn't say us what you found in the basket. I'll finish up with the cerebrovascular. Did you find any debris within?
We found nothing large, but some small stuff.
Small stuff.
Yeah.
So what do you think about the general concept of cerebral protection? You think that there are valves that are more prone to dislodge debris, etc., or you think something, it's a kind of class effect? Do you think that there is a specific valve that needs to be protected or not, in perspective?
I think that's very difficult to say and would be speculation. Coming back to the low-risk trials, we saw really low stroke rates, especially with the Edwards, but if that's because it's a different population, different selection of patients or not, that's completely unknown. What I would be a bit nervous about is to resheet or reposition a valve 3-4 times, and I'm starting to getting a bit nervous.
Kim, I think you have some
Andreas,
answer.
nice case. I have 2 comments or questions. Do you have you considered using the true flow balloon for having a really minimalistic approach?
We have tried it.
Shelf, because I think you have everything in your shelf. But
we have it, yeah. Or had it. We used them. The problem with the true dilatation, maybe you know the balloon or the true flow, is it's like 8 balloons, and you have when you inflate them together, and you will have a hole in the middle and 8 balloons, and with a wrap around. My impression is that the radial force or the strength of the balloon is significantly less than a regular balloon, so therefore I'm not so convinced. And the other problem is that you cannot reuse it for post-dilatation, because if you take it out, it's difficult to rinse it. You will have blood in between these small balloons.
And it is expensive. It's more expensive, and you can do it without rapid pacing, but it is not a guaranteed stability of the balloon either. So in that perspective, I would say,
So we use it particularly in patients with very poor left ventricular function, where we're concerned about even a very short pacing run, and it works very well in that situation. Partly because it's the stroke volume's less anyway, and it's for those of you that haven't used it, the hemodynamics during that are really very, very stable.
You would think it would be unstable since the patients get the aortic insufficiency, but we haven't seen an issue with that either. So seems fine. And
there's different technology on the way. You have this scoring technology with it's called leaflets from Picardia, that also allows you to modify the leaflets, the calcified leaflets, without pacing. There you definitely will not need any pacing. So it is interesting technology. These true flow balloon, but it's not a guarantee for stability, and potentially there is other technology on the way. I just want to come back again to the stroke issue and the remarkable finding of partner 3, where there's only a 0.6% neurological event rate, because it was not only disabling stroke, there were no TIAs and no minor strokes. If you compare that to the Evolute low-risk trial data, there the neurological event rate was 2%. 2% in a low patient population, 73 years old. So why would there be a difference? You might be tempted to think, well, that is because of the SAPIEN, the balloon expandable valve, is associated with less cerebral embolization. I think that contradicts findings from previous studies, where they consistently found debris in the filters in all the valves, with all the valve types, and also with the balloon expandables, there was debris in the filters in 100% of the cases. One of the differences between the 2 randomized trials is the scrutiny in which neurological events or issues were monitored. So in the US low-risk, Evolute low-risk trial, there was a neurologist involved before and after each TAVI procedure. That was not the case in the Partner 3 trial. So you can imagine that if we as physicians are monitoring neurological events, then probably our yield will be less than when a neurologist is looking after the before and after the procedure for neurological issues. So I think that might partly explain it. So I think there is no doubt in my mind that there is debris embolization in all patients, also with balloon expandables. And will they result in clinically significant neurological events? Probably not. But you know that there is this issue with neurocognitive deficit down the road, because there is brain injury, because you see something happening in brain MRIs, and if we want to prove otherwise, then we start to be doing MRI follow-ups, brain studies after TAVI, and see and confirm that there are no lesions, no new lesions. And so and now I'm on a monologue here now, but and I've done it before. I've done it before. But you know, we often make the analogy with a seatbelt. So my question then to you is, how many cars are available without a seatbelt? So I would say, so why would we allow a TAVI without cerebral protection if you know that there is debris embolization in all our patients? So, and I think, and if one of the devices would have more debris or bigger chunks of debris, well, there is no association between lesion size and clinical events or clinical neurological events. And also we don't, a Skoda has a seatbelt and a Porsche also has a seatbelt. So I think that's at least my argumentation in favor of...
Nicolas, can I make a question?
I hate to challenge the chairman. But,
go ahead.
You know, we thought that about thrombectomy, didn't we? You know, we pulled out thrombus. We thought this is definitely the right thing to do. Who in their mind would leave this thrombus in a coronary? You know, I think we need the data. We need the trials. That's, you know, until we have the trial data, we can't uniformly recommend an intervention, which may not always do good. You know, that's why we do randomized trials. If we all knew the answer, we wouldn't do them.
Okay, I'll try to put together the two different views. I think that, you know, it's a completely different animal, you know, the myocardial infarction and the protection in the coronary.
It's an example of where we believe something is correct.
Okay, I'm trying to put you together, yeah. Okay, so the point is the following. That's in the case we have, you know, we might not have any myocardial viability. So, you know, the influence of minimal debris dislocation is clinically close to zero. In this case, we're talking about, you know, the brain is another story. But we have to wait for data. But probably, Nicolas, as long as, you know, the risk is going down, probably the incidence of stroke rates will go down. But the fact this does not mean that we do not have to protect this patient. That means simply one thing, that the relative risk reduction, when the risk profile of the patient is very high, is very big. When we have patients at low risk, pre-test likelihood to have a stroke rate is very low, the relative risk reduction is low, but the absolute risk reduction, considering the amount of patients that we can treat, is very high. It's something that was similar with thrombolysis, you know, the relative risk compared to the absolute risk. So the point is that we need more data, for sure, but actually I don't see any reason to not, you know, sit the belt fastened. So
I'm sure that more data will come eventually, but Raj, are you involved in research? Yes.
Yeah.
You do retrospective studies in your own center?
For hypothesis generation.
But you do it?
For hypothesis
but
generation.
you don't believe it?
I believe they
You don't believe
a hypothesis.
it? You don't believe it? So you do research, but you say, fuck it, it doesn't matter. I'm just going to do it because I want to waste my time. So this is what I'm saying. There is retrospective data from Ulm, from Rotterdam, from Cedars-Sinai. There are meta-analysis of all the randomized trials that all point to a 60% clinical event reduction. So if you say that is all bullshit, then 80% of the data that we're using to support our clinical practice is nonsense. So I think we have to be careful with disregarding data and literature, but I do admit that the pinnacle of research is a randomized trial, and I assume that this is what is in the making.
Yes, okay, I would propose just a special make of car, which maybe is more in the need of a seatbelt than some others. I think that model of car is going to be seen more often in our cath labs. And that's, I think it's the valve-in-valve procedures where I'm more nervous than in other procedures, because we see on the CTs, it's quite often that they have thrombus on the leaflets, which are stenosed. And if I think it would be a good idea to specifically study these patients, which I think are at high risk, and probably the benefit might be larger there. And I'm also quite sure we'll see much more of these patients in the next 10 years.
Okay, I would like just to understand the feeling of the audience. I think it's important you to be engaged in that. Please raise the hand who has the feeling that the cerebrovascular protection matter in, you know, in the TAVI patient, don't think about the risk, etc. So it's like a black or white picture. Raise the hand who believes that is worth going with the cerebral protection. Okay? Only the left-hand side of the room. Why the right? Raise the hand who do not believe in the cerebrovascular protection in the TAVI context. Please raise the hand. And all the others, what think? Is there
Opinion.
you are waiting for further data? Huh?
Maybe.
Huh? Not yet. For the moment, you are skeptical, so this is the reason why you raised your hand.
Maybe I would
Of
like
course,
to
if the largest
take-
study in the
take
field
the,
has 100 patients in the control group or 111, then maybe the data is a bit scarce. That would be fair to say, isn't it?
Maybe I can take the opportunity to ask Nicola. You are one of the in the forefront of cerebral protection. In which percentage of patients do you use cerebral protection? In all patients, or how do you do it?
Yeah, so I use it in all my patients unless there is an anatomical restriction, and that can be the size of the landing zone or the excessive tortuosity that becomes difficult. In principle, the average time to put in the filters is 90 seconds. There's
90
no
seconds,
additional contrast to be used. So it doesn't add much complexity to the procedure. And again, I'm convinced that there is debris embolizing, so I don't want it in the brain. Period.
But let me just. This is the difference between someone like you, who is an expert. If you say it takes 90 seconds, for me it takes much longer. So I'm not in the. I don't have the possibility to use cerebral protection for all patients, mainly due to reimbursement. But I would lie if I say it takes shorter than 5 minutes. Sometimes it takes 10 minutes.
So I understand that reality, and that's why I think it is. It's a little bit disappointing because it is, as Nicola was saying, if and I quote Nicola, if I want to have Didier to do a TAVI on my father or mother, I want him to use a filter. Yeah. So if we start using if we have a selected use of filters, I don't think it's fair towards our patients. Then you need to be consistent. That's what I try. That's what I try to say. So if you would only use it in your own close relatives but not in your patients, what are you doing then? I mean, you should give your patients the best possible treatment.
Do you have a reimbursement for?
No.
Oh, okay.
No. So we negotiate the prices.
He will have for free probably.
No. Well, after this session, yes.
After this session, he will have for free. Okay.
I did my best.
Thank you, Andreas. I think we have to move on to the next speaker. The next speaker is Nicolas van Mieghem, predicting paravalvular regurgitation after TAVI, implication for device selection. Nicolas.
Okay, less controversial. Paravalvular leaks. I think we're all aware of the fact that paravalvular leaks were probably one of the Achilles heels of TAVI in the early days. But things are changing, and they're changing dramatically. And just as a background, if you look in the more darker colors, you see the incidence of mild PVL, and then in the lighter colors, it's moderate. And in blue, it's with the mechanical expansion valve, so the Lotus valve. In yellow, it's the self-expanding core valve family. In darker yellow, it's the evolute, and then in green, it's the balloon expandable. And what is clear is that the incidence of any paravalvular leak is the lowest with the mechanical expanded valve, but you also see that there is a trend in a clear reduction of moderate, in the incidence of moderate or more paravalvular leak with the other devices. And then in the recent Partner 3 trial, I think the moderate PVL rate was as what you would expect, for instance, with the Lotus, but you still have a 30% mild PVL rate. So is mild PVL relevant? Is it clinically relevant? So that is an open question, but it becomes more relevant if we start treating younger patients with a longer life expectancy. And I think there's a lot of debate. I think there was a univariate analysis from Partner, a sub-study, where they suggested that mild PVL was associated with worse outcome over time. There is this meta-analysis published in CCI a couple of years ago, and it did suggest that non or trivial PVL was associated with less events or with a better improved survival as compared to mild PVL. But I think in the larger randomized trials, this has never been reproduced. And if you look at multivariate analysis from different trials, from the Partner family or from the CoreValve family of trials, only moderate and more than moderate PVL was associated with more survival or earlier survival. I think this might change if we move to lower risk patients because, again, the life expectancy is much longer. So it becomes relevant to look into the predictors of paravalvular leaks. And the major predictors are summarized in this slide. And this comes from my fellow and is about to be published in one of the textbooks. There are anatomical, procedural, and post-procedural variables. And in terms of the anatomical, I don't think it comes as a surprise that extreme large annuli, especially at the borders of the sizing charts, that those are associated with PVL. If there is excessive calcium, especially if it protrudes into the left ventricular outflow tract, bicuspid valves and also peculiar aortic angulations are associated with paravalvular leak. Same thing with the implantation depth. The deeper the implant or a very high implant might be associated with incomplete coverage of the annulus and therefore paravalvular leak. And also certain valves are associated with more PVL than others. And post-procedural, while it can always happen, and it's the incidence is around 1%, it's TAVR valve or TAVI valve endocarditis. This is an interesting recent publication that focuses on the Accurate Neo device, where they looked into the impact of device landing zone calcification. And on the left-hand side, you see the number of device failures that are significantly higher when there is severe landing zone calcification. And this also holds true, or this is driven by paravalvular leaks of 2 or more. And you see that the incidence is above 10% when there is excessive calcium in the landing zone of this device. And I think this also holds true for other devices as well. So what are the innovations? And I think this becomes important when we talk about device selection. Well, the important innovation has been around for quite some time, and that is Lotus. But Lotus was off the market for a couple of years for some device modifications. But I think there are some important features that may separate itself from other technology. And I think this complete repositioning and retrievable feature is really extraordinary and can be very helpful in the most demanding anatomy. So the more insecure you are upfront about the aortic route and in terms of proper stent expansion or valve expansion, there I think a device that is completely repositionable, completely retrievable, definitely can be an asset. So the technology has re-emerged to the commercial market a couple of weeks ago. We did our first cases last week, and I can tell you the device improved. It has become more user-friendly. And now, of course, we want to know whether the excellent results in terms of low paravalvular leak incidence is preserved and whether the conduction issue that was reported in the past has been resolved or at least mitigated. The new technology introduces a new eye sleeve, so the profile has improved, so you would expect less vascular complications. It has a more flexible catheter, and the locking mechanism has improved significantly, so the implantation will be faster. Over time, they will introduce more valve sizes, and that also is of interest, especially in the patients with very small or very large annuli. This is a case of us from last week, and it nicely illustrates what the technology can offer to you. This is a Lotus Edge that is implanted right at the annulus. And I'm not aiming for such a high implant, but that had to do with the foreshortening feature of the Lotus in this generation. So it foreshortens predominantly from the LVOT upwards. And you gotta learn to get a feel of that foreshortening. So in this particular case, we underestimated the amount of foreshortening. So as the device was foreshortening, it kept on foreshortening and it landed really on top of the annulus. You see that there is, I would say, mild PVL, but with this technology, you have the opportunity to also correct that. And that's why we decided to reposition the valve. And please look at this radio-opaque marker that is much higher on the left side as compared to the middle. And this is our final angiogram where there is no PVL whatsoever at an implantation that is around 4 millimeters below the annulus, as is reported or as is recommended in the in the IFU. Probably a glimpse into the future. There is already technology, software that helps us decide or predict the occurrence of paravalvular leak. And this is the FEOPS technology that requires a CT scan up front, what we always do for our pre-procedural planning. And then based on the mechanical properties of the tissue and of the device, the technology allows you to predict how much and where potential paravalvular leak would occur. So it allows you to do simulations based on the depth of implantation and the valve sizing. And in this particular case, a Lotus was being used. There was first a simulation with a Lotus 25 millimeter valve, where you see that there is a paravalvular leak of 17 milliliters. And if you then replace this 25 with a 27 millimeter valve, then the leakage is hardly there, so only 0.3 milliliters. So I think this is potential interesting technology that may also help us in device tailoring for TAVI in the future. So in conclusion, I think paravalvular regurgitation after TAVI remains common. The impact of mild PVL is debated, but probably will increase in importance in younger patients. Procedural planning may help select patients at risk for paravalvular leak and may also help determine the right technology for the right patient. So I think with that, I would like to finalize my talk. Thank you for your attention.
Thank you, Nicolas. Do you have any points?
Yeah. Nico, just one question for you. You mentioned the issue of mild PV leak. And according to that, I would like you to share with us what is your routine policy in your center regarding post-dilatation with different devices and how aggressive you are regarding post-dilatation with regard to that issue.
Yeah, I think it all relates to proper assessment and evaluation of the severity of your paravalvular leaks. And as we are doing our cases under local anesthesia, so no sedation whatsoever, TEE is not a good option in our practice. So we rely on a multimodality evaluation. We use transthoracic echo, aortography, and we still rely also on the AR index. And the AR index, it's important. So that's why we do a hemodynamic assessment before and after the valve implant consistently. We have a relatively low threshold to post-dilate, but with the newer technology, with these very appropriate sealing mechanisms and sealing fabrics, I think the rate for post-dilatation is around 20% now, 1 in 5. But our threshold to accept mild PVL is going down.
I have one comment about also this point, because the regurgitation index is important. It's a kind of workhorse measurement that we take, but is strongly influenced by the heart rate. So if you have an heart rate that changes by 10 beats per minute, you have a total different regurgitation index. So one way, a simpler way to go is to make another projection sometimes, and to look at the distortion of the frame, because sometimes the valve seems to be fully opened in left oblique projection, but when you go to the right, you see a clear constriction of the valve. In this case, you might go with a balloon, because it's quite easy in that case to imagine that it's not an intra-valve regurgitation or PVL. Do you use this kind of, multiple view before going to?
Yeah.
And there is another point. It is very unusual to hear during the Congress, but if you measure by angio the width of the cell, of a single cell, you cannot do that with the Lotus, but with the other valve, there is a kind of nominal value of this cell width according to the size of the valve. So sometimes, if you make this cell and you have, for instance, you need to have 6 millimeter or 7 millimeter, you have 3.5, you're pretty sure that the valve is constrained. This is another trick that seems to be, a little bit tricky, but sometimes help.
So we do. I think in 50% when we are in doubt, we would do an additional aortogram in an RAO more caudal projection, and then we apply the video densitometry technology that also Professor Sarois is promoting, and it allows you to have a more reproducible analysis of your paravalvular leak. So it's automated, and so it's no longer your subjective interpretation of the PVL. So this is still work in progress, but it seems to be more and more robust, the data that we get. So that might be an additional feature for the future.
There are any points from the audience? You are too quite full. Okay, so let's move to the next speaker. The next speaker is Rajesh. The new Lotus Edge in complex anatomy, recorder case from Oxford. I'm very curious about that.
Can you bring the presentation or?
You get immediate punishment. You see that?
Yes. Okay, good, thank you. So the three aims of this session now are to understand how to optimize the TAVI procedure to deliver a safe and efficient pathway, where and how the Lotus Edge might fit into that, and give you some idea of a comparison with Lotus Legacy, and to review the implantation technique, and that's going to be the case in the box. So I think the TAVI pathway efficiencies start right from the pre-procedure planning, and we've heard about that already. We need to understand about the comorbidities of the patient, the anatomical complexity of both the valve and the access site, and we need to understand about how suitable this patient is for an early discharge based on their social and functional factors. And those really help you to determine whether you can and safely do adopt a minimalist strategy and to plan your early discharge strategy right from the beginning of the procedure. We've heard extensively about what a minimalist TAVI is in 2019, and the post-procedure aspects then, which we've focused on, are to reduce complications and deliver that early discharge. So in terms of our case, he's an 87-year-old man. He's got increasing breathlessness when cycling. He runs his own business still, so he's functionally very good. And he's got a background history of stable pulmonary fibrosis, which has been monitored. He's had his aortic stenosis monitored, and he's now reached a significant level, and he had a heavily calcified valve. His pre-procedure imaging and workup suggested that he was very suitable for a transfemoral access, and there were no complicating landing zone issues such as low coronary heights or other complex anatomy. So in our workup, he meets those criteria for a minimalist TAVI approach with early discharge planning. So if we look at the procedure itself, the key aims of a minimalist TAVI are to continue to deliver a safe TAVI procedure with minimization of our procedural impact. We want to reduce vascular access complications. We want a predictable valve delivery and positioning with good hemodynamics and little PVL. We want to reduce the risk of pre-procedural pacemaker and reduce the risk of stroke. So in terms of reducing vascular complications, you already saw Andreas use ultrasound-guided puncture using the micropuncture, and really I think that should be routinely adopted. And people often say they use routine puncture and ultrasound, but don't. And I think that is a key step to us providing safe and effective vascular access. We've got evolving sheath technologies, which we've heard about, and we've got evolving closure devices, and we need to understand how those are going to impact on reducing vascular complications. You've heard very elegantly from Nicholas about the importance and strategies to impact on paravalvular leak reduction, and I put this slide up comparing the valves and showing that the results of the Lotus valve give us surgical-like paravalvular regurgitation. The key features then of the Lotus Edge in a heavily calcified valve are the adaptive seal to reduce that PVL, the mechanical expansion and high radial strength pertinent to this anatomy, the fully repositionable nature of the valve to ensure that you can check your result and reposition if you need to, and the specific features of the Edge technology are the increased flexibility of the delivery sheath, the one-view locking with no risk of post-twisting, and the depth guard technology, and allied with an adapted implant technique that should reduce the risk of periprocedural pacemaker. We've learnt from the Piedmont study that going for a high implant is preferred, and that does have an impact on the risk of periprocedural pacemaker. On the left here, you see the graded reduction using the implant technique, so a high implant technique associated with a lower risk of pacemaker. And this video illustrates how the depth guard technology, shown here on the right, causes much less interaction with the left ventricular outflow tract as the valve is delivered out of the sheath. There's some early published data on the Lotus Edge showing that it does translate into a lower pacemaker rate. The numbers are small here, and these are feasibility studies, and we do need to understand whether this is translated into larger numbers. So what I've showed you is how we can implement steps in our pathway to deliver a safe and efficient pathway, how the Lotus Edge works and why it might be suitable to certain kinds of complex anatomy. And the next part is a 4-minute case in the box, which we recorded.
We're going to do a transfemoral TAVI case. Our routine setup is under conscious sedation with local anaesthetic via the femoral approach. We have used the right side is the access for the Lotus sheath. We're deploying a 27mm Lotus valve, which needs the large Lotus sheath. That will be compatible with the 15 French eye sleeve, which will be released later on this year. So that's the setup.
Can you show us the aortogram, please? Just talk us through the aortogram.
So this is the aortogram, the setup shot. You can see that the aortic valve is heavily calcified. It's quite a horizontal aorta. The sinuses are quite large, and the left coronary you can see is a codominant system with good flow. There's a small recessive right coronary. And we're going for a 24mm balloon dilatation. But I think it doesn't need to be as aggressive as some of the pre-dilatations for the other valve systems.
Clip on. Right, Jim, you're on.
Okay. Going up.
Rajesh, you don't have any CTE pictures?
I don't have them on this presentation.
Balloon down.
Facing off.
Okay, and we're ready to deploy the valve. We need to keep the S configuration. We're in the right femoral approach.
Just checking the sheathing there, it feels very good.
We want to rotate the whole device rather than just turn the catheter to align the marker on the outer curve. And that means that the curve then allows
Just follow us up, please.
the S curve to orientate the arch in the right morphology. And you can see there it's really gone round the arch very easily. We're just going to stop this now in the ascending aorta. So we need to line the lower end of the sheath, just a couple of millimeters below the pigtail, below the annular plane. Just there, that's a little bit deep. Maybe we'll just come back a fraction. That's perfect. So I'm going to start releasing the valve. The valve's going to extrude from the bottom end of the sheath. The nose cone is going to come out first. It's now beginning to flare. We're going to carry on releasing this. And remember, it foreshortens from the bottom 4 millimeters, and it needs to lock, so that's good. We've got a bit of foreshortening to come at the bottom. We're at the annular plane. Valve is functioning at this point. Hemodynamics are better. So the nose cone wire, we just need to make sure that the nose cone has plenty of room to run, and it's got to extrude out a little bit more just as we release this valve. It's all beginning to really align now. There's no risk of twisting with this new design of the pillars and the posts. We're not quite seeing. Looking at the locking is much easier now with these more radio-opaque markers. So it's just slowly allowing the valve to lock. There's a nice waist on this valve. Nicely locked, no twisting. Okay, good.
Take this pigtail out, okay?
Yeah.
Okay.
Okay, so we're ready to go to hard stop. You can see the buckles released there, so I'm taking this to hard stop. Okay, good. You can check it's stable. Okay, so we're ready for the release phase. So we're going to open this. I'm going to look at this part of the handle, and operator 1 is looking at the pin, which is central, to make sure that that releases.
Currently just behind the central peg, isn't it?
Yeah. I should not go past the pause sign, which you can see on the handle here.
You can see it going up now, and it's now gone
Now
up.
release the valve. Okay.
Let's go.
So we're going to continue to take this forward. Sheathing aids are now coming off, and you can see those 3 are all off. And that's the valve system release. Now, I'm going to retrieve the nose cone.
Okay.
How many
Okay,
attempts?
good.
Did you,
Excellent.
How many attempts did you make?
So we're going to make an echocardiographic assessment of the valve now.
Hemodynamics are good. So we're checking the valve. Our routine is to assess the valve with echocardiography.
So mean gradient of 5, no aortic regurgitation. Angio on and eject. It's a thing of beauty.
So 33-minute procedure time, and so this gentleman was really eligible for our minimalist TAVI with early discharge. We've showed you the procedure: local anaesthetic, constant sedation, transfemoral approach, LV pacing, no RV wire, transthoracic echo to guide optimal result, good hemodynamics. He did develop new left bundle branch block. And in terms of his post-procedure recovery, he developed no vascular complications or stroke. There was no progressive conduction disease. We monitored him for a little bit longer, and he was discharged home at 48 hours. So I hope we've showed you how even complex anatomy or relatively complex anatomy can be treated in this minimalist pathway, to understand how the lotus edge system can fit into that, and we've revised the implantation technique. Thank you very much indeed.
Thank you, Rajesh. Could you explain a little bit better what has changed compared to the previous edition of Lotus?
Yes, the main differences have been the change in the sheath itself. It's much more flexible, the delivery sheath itself. The posts used to be circular. They're now a D morphology, which means that they can't twist. So you don't need to do that maneuver where we used to look at whether the posts were twisted, the tuning fork maneuver, if you remember. We don't need to do that anymore. There's now a radio-opaque marker, so you can see much more clearly the locking. You don't need to stare and try and work out whether you've got locking. It's one-view locking because of that anti-twist mechanism. The device is more flexible, and the adaptive seal is a bit longer.
What about, what's your perspective in terms of events? I'm looking, for instance, the stroke rate and the pacemaker rates in the previous edition of Lotus were a little bit high. What do you expect with this new release, etc.? Something better? Why?
So I think, well, the adaptations, the delivery sheath is certainly much more flexible. So there is, to learn that should make the valve delivery easier. There should be less interaction with the aorta and possibly, therefore, less embolization, and that should help. I think part of the problem is you know, sort of the things we've been discussing about the fact that if it's a heavily calcified, difficult valve, that's when you use the Lotus, because you didn't have, you know, that was your preferred system, and therefore some of the signals we're seeing in registries may reflect the fact that it's being done in more complex anatomies. So I think it's, you know, it's difficult to make direct comparisons.
Yes, I have a question about the QRS and the ECG and the pacemakers afterwards. You were doing the case without a transvenous pacemaker lead, I noticed. Isn't that correct?
Yes, it is. So we use left ventricular pacing as our default pacing strategy.
Yeah, great. And with this valve, would you be more afraid than with other valves that you get a later onset AV block that's after 24, 48 hours or even later, that you need to keep them longer in hospital, or is it the opposite, that either you get it or not?
I think most of our experience with legacy Lotus was you either got it very early or you didn't. Most of the damage is done during the procedure. I think there are some concerns about, we alluded to this earlier, didn't we, about whether different valve types need different periods of monitoring, and I don't think we truly know the answer to that yet.
And one more question, maybe not important to this 87-year-old gentleman, but I have a couple of younger patients where I thought which is the ideal valve. Young patients with bicuspid valves and small anatomy. And then there is one other concern, that's the future coronary access if they get coronary disease in the future. What do you think about that?
Well, as you know, there are, I mean, one advantage of this valve is you can reposition it, you can place it where you want to, you might have to go deeper. There are the next iterations of the Lotus valve will have a lower frame height. We're not there yet, but one of the key advantages is you can check that positioning, and if that's something that is very relevant to you, then you can reposition it. You may have to accept a higher pacing rate.
Maybe one question. I've seen that you have done a pre-dilatation. Do you do it routinely for Lotus cases? Because
we didn't.
We have done a few cases with Lotus, but most of them without pre-dilatation.
Our consecutive series, which we've published without pre-dilatation, was our default strategy. I think with the change in the delivery system, that there may be some. There's a learning curve to be adopted. As you know, this device has just come back, and we wanted to follow the rules for our initial series, I think.
This is true, because with a very early experience, when you had a severe calcification, you didn't go with the pre-dilatation. Sometimes it was really difficult to get connected with the back of the
it looked like a mushroom, didn't it?
Yeah, like a mushroom. But, you know, we have to, you know, to share with the audience that this, you know, at first attempt, even though it was a failure to close the valve, worked as a balloon pre-dilatation, because it was a mechanical expansion of the valve. So you don't need to go necessarily with the balloon, because the working unit of the Lotus works as a mechanical expansion, and you may reduce also
and I think
the swinging within the valve.
I think that's right, but I think what we don't understand is what effect that has on stroke rate, cerebral embolization, whether using a device to do that is different to a balloon. I mean, I think there's a lot to learn about that.
In terms of the conduction disorders that you will encounter after any valve implant, in an 87-year-old, what would be your default strategy? You do a daily EKG, and then you monitor the QRS duration and the PR interval?
Yes, exactly right.
And if they start to
any
narrow,
change,
then
absolutely. Any change, we have a very low threshold for saying pacemaker. If it's not better by 48 hours, or if it's certainly getting if it's still the same, we may keep them in longer, depending on where they are, how distant they are, and that's the point I was making about their social factors and where they are in relation. You know, we get referrals from very distant paths, and we like to keep those patients for longer. So
I agree with that. So especially with early discharge programs, you really have to address the social circumstances to that patient. And I think in terms of the monitoring, what we do is that we do daily EKGs, and the moment we see that the QRS is narrowing again and the PR interval is also narrowing again, then it is safe to discharge the patient.
Absolutely, agree,
Last point, Rajesh, do we have more sizes compared to the previous edition?
There will be. They aren't there yet. As Nicholas showed, there'll be a 21 and a 29, but not yet available.
Thank you, Rajesh. Thank you. So the last speaker is for session evaluation and key learnings. It's a pleasure to invite to the platform Kim.
So thank you very much. It's a great pleasure and privilege to give you a short summary of what we hope to have learned in this session. So I think we have seen two very nice cases showing what is possible with TAVI in 2019. And if you remember, TAVI set up back in 2008, what we were in need, anesthesia, intubation, central venous line, etc. Also here a venous line for a safety net. May I ask who in the audience is still using a safety wire in the vein? A standard approach? Raj, I've seen that you use it.
Yeah.
We don't use it anymore because actually it's for getting faster on pump, and last year we had 4 cases of conversion and 2 of them were not emergencies, so I think it's debatable whether you really need all of this setup. And another example, we started with inserting a 4 French sheath in the superficial artery, and this is only a small example of what can happen with only a 4 French sheath. So I think hybrid OR setup in 2019 or even 25, I think you can reduce most things, but I think it should not be too simple. And to summarize the TAVI streamlining, I think that TAVI is ready for streamlining. We have seen there is improved technology. We have a lot of data. There is sophisticated imaging, sizing. We have more experienced, lower risk patients. And I really think that streamlining is mandatory because it decreases the resources you require and you can really reduce procedure risk. Why should we do things that we don't really need? And if you look at this example, which I would really like to show, this is a picture that I was allowed to take when I was proctoring in Siegburg. And this is one of the first core valve implantations by Eberhard Grube. And you can see how big everything was, and I think this was a 28 French device, and in order to get over the aortic arch, you may see that here a snare was required, and this is what we needed back in 2006. So this doesn't mean that we have to continue with that, and that's why I think that streamlining is really important, and we really have to focus on those things which are necessary for the procedure. And we have seen 2 very excellent examples of how streamlining can facilitate early discharge. One consideration is that I think, it's my personal opinion, any simplification, and I've seen many, many different centers and so many different approaches to doing a procedure. So I think, in the meanwhile, that any simplification of the TAVI procedure must be tailored to the individual center's logistic, to the operator's experience and availability of bailout options. So we have seen a very interesting talk about cerebral protection, and it's also my true opinion that cerebral protection during TAVI is necessary. And we know that cerebral embolization occurs in the most cases and is associated with stroke, clinical overt stroke in 4+%. It's difficult to predict and may be associated with additional sequels, delirium, cognitive dysfunction. And I think there are some open issues, including reimbursement. I think this is one of the most important issues to work on. Procedure integration. We have seen a very nice example of how you can integrate cerebral protection into the procedure without prolonging it. I think we have to work on complete anatomical protection and also post-procedure stroke. We have heard on paravalvular leakage, which is still common after TAVI. We have learned that it affects prognosis. And there's different predictors of paravalvular leakage, anatomical, procedural, and also post-procedural factors that might help to select the best valve or patient. And we have seen, we are introduced to new generation systems that have features to mitigate paravalvular leakage with sealing skirts, repositionability, and going to surgical like PVL rates. So I think what we have to take into consideration is that elimination of PVL might be there might be a trade-off with pacemaker implantation, and I think this is also something that we have to work on. Thank you very much.
Okay, before closing the session, a very rapid and quick opinion from this with the last point. Is it possible to disconnect PVL pacemaker rate? What do you think?
Yeah.
Yeah. What do you think, Monte?
I think so, yeah.
It has been shown already, hasn't it, in a study in March?
Rajesh?
Yeah, I think it is.
So Kim, everyone.
I think it really depends on the design of the valve. If you take the classical device, you really required radial force to get a competent valve. And I think with modern devices, it's a different play. I agree. But
yeah, I think
talking about routine.
I do agree. I think with the improvement of technology, the changing of the cell design, because moving from the closed cell, open cell, and the way we wrap outside, you know, the valve, the bottom part of the valve, I think will matter in terms of this connection. We are perfectly on time. I would like to thank all of you for attending this session. I would like to thank mostly the filter man, my co-chairman, it is Nicolas, and then all the other speakers, Dumontel, Rook, and Kim, and Rajesh. Thank you to all, and good evening. Bye-bye.